Hello, everyone. Am I audible? Please put in the chat box, in the comment box, whether I'm audible or not. Am I audible, dear children? Please put in the comment box. Am I audible? Yes. I think I'm audible. Okay, fine. So first and foremost, a very good afternoon, everyone. I welcome you all to the important series under your plan MSc 5.0. So this is a live probable MCQ discussion session, which we used to have to enhance our question sensing skills and answering skills in your MSc nursing entrance examination. We used to conduct these sessions where we're going to discuss about the most important MCQs which can be probably asked in your upcoming MSc nursing entrance examination. And my heartfelt wishes for the students who have secured n number of seats in uh, various nursing colleges, various good nursing colleges, reputed nursing colleges. After utilizing Plan MSc maximally, I was frequently having a lot of messages from the students that, like, ma'am, we have cleared in Jikma, we have cleared in uh, West Bengal, and a lot of messages, right? So I hope this Plan MSc 5.0 was really useful in your preparation journey. And all the very best, and my heartfelt congratulations for the students who have cleared their examination and or who are successfully pursuing their masters in reputed and prestigious nursing colleges, right? So today, let's go into our Plan MSc live probable MCQ discussion session. So here I'll be showing you a series of MCQs and we're going to discuss in detail about that MCQs, including the correct answers and the distractors as well. And now you people have to answer me so classically so that we always have a good connect. So let me display the first MCQ in front of you all. Yes. Now here you have the question. A nephrotic patient urine analysis reveals Maltese cross. It is telling the urine analysis, which means we have collected the urinary sample of the patient, and this urine analysis is showing Maltese cross appearance under a polarized microscopy. Which laboratory finding would you most expect in the conjunction with this microscopic finding? And most important thing you have to remember in MSc nursing entrance examination, this session is exclusively for the MSc nursing entrance examination students. Thank you, Nituba Singh. Thank you so much. Yes. So this session is exclusively for the students who are preparing for their MSc entrance examination. For NOSET perspective also, this will be helpful for you, but it is primarily targeting the MSc nursing entrance examination. Right. So when coming back to the question, so how MSc nursing entrance examinations questions will be? If you're going to go detail into those papers, you'll be having only one shot MCQs, which is going to state like, what is the answer for this? So it is going to test you clinically as well as analytically, and most of the questions are memory-based questions, right? So it is very important to understand these things before preparing for these examinations. So coming back to the question, a nephrotic syndrome patient is showing her Maltese cross appearance under polarized microscopy. Which laboratory finding will be most expect in this conjunction with this microscopic finding? Now, any answers in the chat box? The students who are the advanced learners can put your answers in the chat box. First and foremost, what is nephrotic syndrome? What is nephrotic syndrome? How we are defining the patient as a case of nephrotic syndrome? As you all know, nephrotic syndrome is a problem or the disease condition or group of disease condition which is affecting the nephron. Right. Here, the classical feature or the diagnostic element to identify the patient as a case of nephrotic syndrome, what are they? First and foremost, the PCR ratio, the urine protein creatinine ratio. The urine protein creatinine ratio, specifically in terms of the urine, you have to remember the urine protein creatinine ratio is going to be greater than 200. It is going to be greater than 200. Sorry. It's going to be greater than 200 mg per gram. The urine protein creatinine ratio is going to be greater than 200 mg per gram. The next and most important scientific definition, the loss of protein in these patients in the form of proteinuria is going to be greater than 3.5 grams per day. It is going to be greater than 3.5 grams per day. And what are the additional features the patient may explain? The patient may have. So first and foremost, we have talked about the protein creatinine ratio, where the patient will be having greater than 200 mg per gram of protein presence in the PCR ratio. Next, the second one is the loss of protein. Proteinuria the patient will be having, that too, the amount of proteinuria is very, very important to be remembered. That is going to be greater than 3.5 gram per day. Along with that, the patient will be having hypoalbuminemia. Hypoalbuminemia. Since protein is lost, it is very, very important to know that the patient will be going for hypoalbuminemia, which means the ratio, what is the quantity of this albumin level? The patient will be having less than 3.5 grams of albumin in the blood, right? So what is the most important classical thing you have to remember when you're studying about albumin? Albumin is an important component which maintains the oncotic pressure, So what is going to happen if the oncotic pressure is going to be reduced? If the patient is going to have hypoalbuminemia, obviously the patient is going to have the reduced oncotic pressure. So if the oncotic pressure is going to be reduced, what is going to happen? The patient edema will be there. Why edema? The oncotic pressure is the pressure which helps the blood vessel to hold the fluid, But here what will happen? Because of reduced oncotic pressure, the fluid inside the blood vessel will leak to the extravascular space. The fluid in the blood vessel is going to leak into the extravascular space. For example, I should have a good amount of blood circulation and I should have a good oncotic pressure to maintain a proper circulation. So in this case, what is happening? My oncotic pressure is reducing because of hypoalbuminemia. Yes, very good. Very good snapshot. Snapshot by Aish. Very good. So what's happening here? The oncotic pressure is reducing. So what is happening? The fluid is going to shift or leak from the intravascular space to the extravascular space. So when there is a continuous leak of fluid from the intravascular space to the extravascular space, what is going to happen? Ultimately, there will be accumulation of fluid in all the third spacing area. So what are all the third spacing area? For example, the patient will be having peritonitis, the patient will be having pleural effusion. So in which are all the areas it is inappropriate for the accumulation of fluid, that will be happening on the other hand because of this oncotic pressure. So this is again one of the important classical feature you have to remember while studying about nephrotic syndrome. What is the next case? The tetrad, in that tetrad of nephrotic syndrome, the last one is hyperlipidemia. It's hyperlipidemia. Okay, either the patient may be present or not present with lipiduria, which means if the patient is having hyper level of like more amount of lipids accumulation in the blood, so there are a lot of chances because of the affected nephrons, there is a lot of chances the lipid particles can also release via the urine, right? So the patient will be having hyperlipidemia. So this hyperlipidemia will be accompanied with lipiduria. In most of the cases, the patient may have lipiduria or may not have lipiduria, right? So this is the most important thing you people have to remember whenever there is a question on nephrotic syndrome. The important keywords which you have to see is about the loss of protein in the form of proteinuria that is going to be greater than 3.5 gram per day. That is going to be greater than 3.5 grams per day. So next is the urine protein creatinine ratio. So that is going to be greater than 200 mg per gram. So next, the patient is going to have hypoalbuminemia because of excessive loss of protein. Albumin is one of the important component of protein. So definitely because of the loss of protein, the albumin level is also going to be simultaneously reduced. That too, it is going to be reduced less than 3.5 grams. Right. So since the protein level is reduced, okay, and the body is not having enough amount of energy in order to produce the metabolic event. So what is going to happen? The liver is going to create a counter-regulatory mechanism where it is going to produce more lipids. So that's where the patient is going to have hyperlipidemia. So hyperlipidemia can be accompanied with lipiduria or it cannot be. But if the patient is having lipiduria and he is a case of the nephrotic syndrome, on microscopic examination, you can see a classical feature of this Maltese cross appearance. So this is a key clinical sign you have to remember, because if there is an MCQ which is going to test you where Maltese appearance is seen, so it is closely contracted with your nephrotic syndrome. When the patient is a case of nephrotic syndrome and if he is having hyperlipidemia accompanied with lipiduria, the lipid particles in the urine is visualized with the help of the microscope, and that will be visualized in this form. So this is termed as your Maltese cross pattern. So on examination, on urinary microscopy, this fat particles will be seen in this format only. That's where we are telling this Maltese cross appearance in the urine is closely associated with nephrotic syndrome. So this is a microscopic feature. When they're going to test you so clinically, so getting a tough question into this, they're going to ask you this question, right? So always remember this. Then again, when coming back to the MCQ, we have already discussed what are the classical features of nephrotic syndrome, right? So the protein creatinine ratio is going to be greater than 200 mg per gram. So here you can see the first option, which is stating the urine protein to creatinine ratio is greater than 200 mg per gram. So again, so that will be the correct answer. We will also see the distractors. So red blood cell cast. So here you have to remember there are two conditions with a similar tone. One is nephrotic syndrome, another one is nephritis, right? Nephritic syndrome, right? So what is the difference between nephrotic syndrome and nephritic syndrome? In nephrotic syndrome, primarily the important part you have to remember is proteinuria. But in nephritic syndrome, there is an infection and inflammation of the glomerulus. But in nephrotic syndrome, what is happening? There is a specialized structure called podocyte. In your glomerulus, there is a specialized structure called podocyte, right? So as you all know, nephrons is the functional unit of your kidney, right? So what is happening? In the glomerulus, if you see the cross section of the glomerulus, you will be having blood vessels, right? That is made up of endothelium, right? Then you will be having the glomerular basement membrane, right? Very good. Someone has tested about MCD. Very good. What does mean by minimal change disease? Minimal change disease is what we are discussing about right now. So next is the green color layer is your glomerular basement membrane. So at last, we have this classical structure, which is termed as the podocyte. This is termed as your podocyte. So what is going to happen? If the molecule is going to be a very big molecule like RBC, this primary blood vessel layer will block it, right? It is going to be a medium-sized molecule, the glomerular basement membrane will block it. If it is going to be a very, very small molecule, which is going to be dissolved in the urine, the podocyte will act on it and it will drop it. So here in case of nephrotic syndrome, primarily you people have to understand this. The podocyte is damaged here. The glomerular podocyte is damaged here. That is otherwise known as podocyte effacement. Otherwise, they will be telling it is a podocyte effacement. Effacement means what? Something which is erasing, something which is eroding, or its distribution is reduced. So that is termed as effacement. So in microscopy, you can see podocyte effacement in case of your minimal change disease. Again, please give a big round of applause to Ashish. So it is a minimal change disease where you can classically find the patient is having a podocyte damage. And when they're going to have an MCQ, another MCQ, I'll tell you. So when there is a when the question paper is telling what is the most common form of nephrotic syndrome, which is seen in pediatric population, then what will be the answer? Now tell me, what is the most common form of nephrotic syndrome seen in pediatric population? Come on, answer in the chat box. What is the most common form of nephrotic syndrome seen in case of pediatric population? As I said you, nephrotic syndrome name itself, it implies it's a group of disease condition, right? Now you have to tell me what is the very common condition which is seen in case of pediatric population. You have to close your eyes and take minimal change disease. Minimal change disease is most common in case of pediatric population. Very good, Aish. So minimal change disease is very common in case of your pediatric population. On the other hand, what is most common in case of adult? What is the most common disease condition which is associated with nephrotic syndrome in case of adult? That is your focal segmental glomerulosclerosis. So most common in adult, it is focal segmental glomerulosclerosis. On the other hand, it can be in shortly said as your FSGS. It is otherwise in shortly termed as FSGS. So this is again, we had a quick review on complete nephrotic syndrome. Coming back to the red blood cell cast. As I said, nephrotic syndrome is a podocyte damage. Nephritic syndrome is where the actual nephron itself is damaged, which means coming back to the layers of the glomerulus, here the vascular endothelium will also be damaged, right? The endothelial layer will also get damaged in case of nephritis, right? In case of nephritis. So what will happen if the vascular layer is also getting affected? The endothelium is also getting affected. So here the RBCs will start to leak inside the urine. So one of the classical feature of your nephritis is the red blood cell cast in the urine, right? So always remember RBC, so hematuria is seen in case of nephritic syndrome and not in nephrotic syndrome. There is possible chances of RBC cast in nephrotic syndrome also, but when the condition is getting more worsened, at that time only you can see that particular change. So next is positive urine culture with gram-negative rods. There is maximal chances that the patient with nephrotic syndrome can have any form of opportunistic infection. which means there is loss of protein, there is loss of lipids, and there is loss of immunoglobulins also in certain cases. So the patient is going for lots and lots of immunocompromisation. So the patient will be having this particular symptom also. But you have to compare, which is very important, which is very close to the answer. Right. So this quantitative analysis of the urine protein creatinine ratio will be more prominent, because maybe urine positive urine culture and of with gram negative rods you can see in some other conditions also, but which is very specific to nephrotic syndrome, that you have to choose in the answer. This is where the competitive exam chooses MCQ for you to clearly tackle it. Right, you should classically identify which is correct and which is not correct. Right. So next is the urine pH will be less than 5.0 with uric acid crystals. Uric acid crystals are not so much classically seen in case of your nephrotic syndrome. So we are rejecting all these three options, and the correct answer will be option A. That is, your urine protein creatinine ratio will be greater than 200 mg per gram. Right? Is it as clear? If it is clear, please put in the comment box it is clear. So next we will go to the next MCQ. So the next MCQ which you're going to see, a 42 years old patient. Okay. Okay. So a 42 years old patient with nephrotic syndrome, the serum albumin is 2.2 grams, 2.0 gram per DL, and 24 hours urine protein is 6.2 grams, which means in nephrotic range of proteinuria is going to be greater than, nephrotic range of proteinuria is greater than 3.5 gram per DL. So obviously, this is classically telling us that the patient is a case of nephrotic syndrome and develops unilateral leg pain and swelling. Develops unilateral leg pain and swelling. D dimer is elevated at 850 ng per ml. Now answer me in the comment box. What is the normal D dimer? What is the normal D dimer? What is the normal D dimer range? Diagnostic range. Now tell me, what is the normal D dimer range? So here the patient D dimer is 850 ng per ml. And which anatomical location is most common site for initial DVT formation in this patient? So they are classically asking which anatomical location is most common site for initial DVT formation. Maybe the first few lines, if you can read it out properly, that is completely a time consumer kind of lines. The primary question which they are asking to test you is, which anatomical location is most common site for initial DVT formation? So whenever we talk about a case of DVT, what is the most common site? Now answer me in the chat box. What is the most common site of DVT formation in this patients? Any answers? Ayush, what about others? Yes. See, the most common site for initial DVT formation in this patients is always your deep vein of the cough. Okay. The primary DVT will be affecting, all that is DVT means the stasis of blood, and it will go into the hypercoagulatory state and it will form as a thrombus and it will be accumulated in the vein valves, right? So deep vein of the calf or the primary location where this particular condition is affected whenever the patient is in the state of hypercoagulation, right? Now I'll ask you a classical question. Whether patient with nephrotic syndrome is at the risk of developing thrombosis or DVT? Any student can answer me. The patient with nephrotic syndrome is had the chance of DVT or not? Obviously, it is yes. Nephrotic syndrome causes loss of antithrombin 3, antithrombin 3, and protein C and S. So this is going to cause hypercoagulatory state, and nephrotic syndrome patients are at a higher risk of developing deep vein thrombosis. Right. So the primary or the most common location for the deep venous thrombosis is your deep veins of the calf. So once the patient is going for the deep vein calf DVT, next the condition is going to be developed from the distal to the proximal. Okay, it will be starting as a distal DVT. Okay, it is starting as a distal DVT. Yes, distal DVT. Very good, Tanya. Obviously, a patient with nephrotic syndrome will be going to the hypercoagulatory state, and he will be definitely at the higher risk of getting deep venous thrombosis. Now tell me, so distal DVT to proximal DVT. Okay. So first the patient calf muscle is affected, right? Then what will be affected? First is calf. Next it is going to be your popliteal. Okay, next is going to be your popliteal. And next, what is affected? Next, your femoral vein will be affected. Please answer in the chat box. At last, your iliac. Iliac will be affected. So this is how the condition, when you're not treating properly DVT at the calf stage, it will be promoted to popliteal, to the femoral, and to the iliac phase. Right? So this has to be very clear for you. But the primary location for the occurrence of the disease is going to be your deep veins of the calf. Right? So once they are going to popliteal, femoral, and iliac, you will be start to seeing the symptoms. Initially, when the patient is having a DVT in the calf, the patient will be asymptomatic. But later, when the patient is going to the progression of the disease to popliteal, femoral, and iliac, what is going to happen? It is going to cause symptoms. The patient will become symptomatic, where you can see this paleness and all. And here again, the most important triad you have to learn. What is the name of the triad? That is your Virchow's triad. That is your Virchow's triad. Right. So what are the components of your Virchow's triad? This is a very important question which is asked in many competitive nursing examinations. Now tell me, what are all the three components which comes under Virchow's triad? I'm waiting for your answers. Yes, please answer in the chat box. So first is stasis. First is stasis. Next is endothelial injury. Endothelial injury. The last component is hypercoagulability. Hypercoagulability. Right? The patient with DVT will be definitely having this Virchow's triad, right? This combination of symptoms where the patient will be having the stasis of blood in the venous and endothelial injury. Whenever the patient is having a DVT, what is going to happen? That particular blood vessel layers can be easily affected with any form of trauma, right? And what will happen? The thrombi will be mobilized from that particular part, and it will go and obstruct some of the important arteries where the pulmonary embolism risk is very higher in case of DVT patient. That's where we treat them with what therapy? Now tell me, what is the management of deep venous thrombosis? Very good, Aish. Very good. What about others? Why you people are not interacting? Please put your message. Yes. Now tell me, what is the management of DVT? What is important? Again, this management is going to be a very important question. What is the management of DVT? What is the drug of choice? What is the drug of choice? The drug of choice in the management of your DVT is your warfarin. Okay, that is a primary drug of choice, right? So the primary drug of choice in the management of DVT is your warfarin. So definitely, while the patient is taking warfarin, it is very, very important to monitor the levels of PT and INR, right? In case of heparin, what you're going to monitor? In case of heparin, you will be monitoring APTT, that is your activated partial thromboplastin time. But in case of warfarin therapy, you're going to monitor PT and INR. So that is the drug of choice in the prevention or in the management of your deep vein thrombosis. So next is popliteal vein at the knee joint level. No, once the patient is getting a deep vein thrombosis in the deep calf vein, then it will be progressing to the popliteal, then to femoral, then to the iliac veins. So we have an important sign also that is also frequently asked. Very good, Ashish. We have an important sign that is also very frequently asked in examination. What is the sign which you see in patient with DVT? You will be assessing clinically one sign. That is your Homan sign. I hope many of you know. Your Homan sign you will be monitoring in case of the patient with DVT, right? So this Homan sign, when you do a dorsiflexion of your lower extremity, very good, Ashish. Very good, Huzaif. Sorry, very good, Huzaif. Very good. So whenever the patient is getting affected with DVT, you're going to perform Homan's examination and you will see the Homan sign positive. When you do a dorsiflexion, when you perform a dorsiflexion of your lower extremity, what is going to have the patient will be feeling a pain in the calf muscle that is termed as a positive Homan sign. So this positive Homan sign also in all kind of DVT it will be seen, but it will be very prominently seen in case of your popliteal vein thrombosis and femoral vein DVT. Right. In case of popliteal vein and your femoral vein DVTs, this Homan sign is very classically positive. Right. Next is your iliac vein in pelvis. So once the femoral vein is also affected, which means it is very serious, and the patient will be becoming very symptomatic. So after the femoral vein also, if you're not treating the patient properly, then the patient is going to get affected with the iliac vein, right? So what is going to happen when the patient is going to affected with iliac vein? Now tell me in the comment box. If the patient iliac vein is affected, what is the case? You'll be seeing an important clinical feature. What is that clinical feature? Answer me in the chat box. See, initially when the patient is getting affected with the femoral itself, we will be maximally trying to treat this patient. But if you're not treating it, it will go to the serious complication where the patient is getting affected with the iliac vein, right? So here in this iliac vein DVT, the chances of this is very like only 5% chances of DVT in the iliac vein is possible. But if it is arising, it is very, very serious and it will lead to this two important classical conditions. That is your phlegmasia alba dolens and your phlegmasia cerula dolens. Okay, your phlegmasia alba dolens and your phlegmasia cerula dolens. Okay, so this is cellular. So first, what is meant by alberdolens? Alberdolens is white leg, like milky or white leg. That is a classical feature of the alberdolens. And it is first described in pregnant and postpartum women because of the compression of the iliac vein. They can be presented with this. But in DVT, in more severe cases, we can see this kind of symptoms, right? That is the total occlusion of the deep iliofemoral venous system. Once the femoral vein is affected, then it is affected with the iliac vein. So here, when there is a total complete occlusion of the iliofemoral venous system, you're going to see this phlegmasia alba dolens, where there is a milky white leg. Okay. So on the other hand, here you have your phlegmasia cerula dolens. This is because of the complete necrosis. there is complete absence of, there is a complete absence or there is a obstruction of the vein, and this is causing a venous gangrene, and this is causing a venous gangrene. It will be progressing to venous gangrene. That's why the limbs are looking so darker, right? So you can see both the cases in case of your DVT, which is affecting your iliofemoral vein. Right? Am I clear? When you see these images in your competitive examinations, or when you can hear this name, your phlegmasia albadolens, that is alba, you know, albinism, alba means white. Whereas your phlegmasia cerula dolens, which means there is a gangrene formation and gangrenous formation, which is progressing, right? So that's where the leg is looking quite reddish. Come on, let's go to the next question. A 32 years old, thank you, dear. Thank you, Huzaif. Huzaif, you're preparing for MSc Nursing entrance examination or you're preparing for NORCET examination? For NORCET aspirants also, this will be very useful because the questions are taken so high end. So it will be useful for you. Yes, yes, yes. Very good. Yes, coming back to the third question. Now answer me classically. Be very active. Yes. A 32 years old patient with progressive dyspnea undergoes right heart catheterization. A 52 years old patient with progressive dyspnea undergoes right heart catheterization. Which hemodynamic finding confirms the diagnosis of pulmonary hypertension? So here you're going to classically tell me what is the definition. Yes or no? Yes, then this class will be very, very useful for you people, because when you're preparing for senior nursing officer examination, the syllabus of MSc nursing entrance and SNO is quite similar, but you will be having a more clinical based questions. Right? Now tell me what is the correct answer. The patient is done with right heart catheterization, and what particular option is telling the patient will be diagnosed for pulmonary hypertension according to your current diagnostic criteria? People are answering C. Be very specific. What is the answer? Actually, the correct answer is A. The resting mean pulmonary artery pressure greater than or equal to 20 mm of Hg is confirming the diagnosis of pulmonary hypertension. And the most important thing you people have to remember is right heart catheterization is the gold standard method. Is a gold standard method to identify the pulmonary hypertension or to monitor the pulmonary artery pressure. The most important gold standard method is right heart catheterization. The non-invasive method. What is the non-invasive method? The non-invasive method which we can use is your echocardiography. Okay. But the classical method we are going to use is going to be your right heart catheterization. So it is already done for the patient. So now you have to remember what is the diagnostic criteria of your pulmonary artery pressure. When we are diagnosing the patient as a pulmonary hypertension, what is the diagnostic criteria? The mean pulmonary artery pressure should be greater than or equal to 20 mm of Hg. The mean pulmonary artery pressure should be greater than or equal to 20 mm of Hg. Now tell me then, what is the normal pulmonary artery pressure? Yes. Now tell me, what is the normal pulmonary artery pressure? In the chat box, please answer me. What is the normal pulmonary artery pressure? The normal pulmonary artery pressure. I'm waiting for your answers. See, the normal pulmonary artery pressure is 8 to 20 in classical. Or even if any other books are telling, it should be 14 with plus or minus 3. Plus or minus 3 mm of Hg, it is normal. But in 2018, according to WHO and other important pulmonary medicine related forums, we're telling we will confirm the diagnosis. The patient is a case of pulmonary artery hypertension when his blood pressure, when his mean pulmonary artery pressure is going to be greater than or equal to 25 of Hg. Right? Greater than or equal to 25 of Hg. But the current diagnosis, the current update as per your WHO and everything, it is going to be what? It is going to be greater than or equal to 20 of Hg. Why this was changed from 25 of Hg? The diagnosing criteria for pulmonary artery hypertension is changed by 25 of Hg to 20 of Hg. So why this change has arisen? Because there is highest mortality at the rate of 20 to 25. Like, after from 21 to 25, the death because of pulmonary hypertension and the range is greater than or equal to 25 of Hg. So what they have done, conducted various research studies, and they have made it the diagnostic criteria of pulmonary artery hypertension will be less than or equal to 20 of Hg. Right? Am I clear? So A is the correct answer, right? So next we will go to the next question. Which of the following finding is most characteristics of dialysis access steal syndrome in a patient with the atriovenous fistula? So one of the most common complication of your atriovenous fistula, which we do in case a patient is a case of chronic CKD and he needs a recurrent hemodialysis. At that time, we are going to have a arteriovenous fistula, where we are going to connect the artery and venous, and we are going to establish the hemodialysis. So now tell me, what is the classical feature or most common characteristics of a patient who is a case of dialysis access steal syndrome? Wow, big round of applause to Hosaifen Ayush. Yes, the correct answer is distal limb ischemia with pain, pallor, and reduced pulses. Yes, can you add a few words about what is dialysis access steal syndrome? Ashish and Huzaif. What is dialysis access steal syndrome? Yes. Also called as artery steal. Yes, yes, correct. We have other names also for this. So, as the name implies, you have a word steal. Someone is stealing something, right? So, what is going to happen is here the patient with hemodialysis with AV fistula, the blood flow, the arterial blood flow, primarily what will happen? The arterial blood flow will be stealed. Will be stealed or stolen by the, yes, 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 and dialysis disequilibrium syndrome is different, and this is different, right? So what is going to happen? The arterial blood flow will be stealed or stolen by the low resistant AV fistula. As you all know, AV fistula is the combination of both artery and veins. So from the artery, the circulation to the distal limb has to be established. And this is very common in case of your brachial AV fistulas. This is very, very common condition which is associated. So what will happen when there is a proper AV fistula which is presented? The blood circulation from the distal part of the hands. For example, here is the AV fistula, and here the distal part will not be having enough circulation. since the blood feels so easy to get inside the AV fistula, it will be going inside easily into the AV fistula without properly reaching the distal part of the limb, right? So that is where your dialysis access steal syndrome is happening because of the AV fistula. Since the AV fistula is going to have a very low resistance, okay, your vascular resistance will be very low in your AV fistula, which will make the blood more attracted towards that particular line rather than going into a pressurized line to give a proper circulation. Okay, the blood supply to the distal part from the fistula side get reduced. Yes, very good. What happened? In spite of going properly from the artery, the arterial bed, in spite of going properly, what will happen? It will divert into the AV fistula and it will travel inside. So that is the concept behind this. That's why it is termed as access steal syndrome. The AV fistula access which we have created for dialysis is stealing the proper blood supply to the distal limbs. So whenever there is a poor blood supply to the distal limbs because of this condition, obviously the distal limb will be having ischemia, and it will be painful, and it is going to be paler, and it is going to have a diminished pulse or reduced pulse, right? So what is this? Increased venous pressure with fistula cannulation. When there will be increased venous pressure, now tell me, increased venous pressure, there is another condition called as venous outflow obstruction. Venous outflow obstruction. When the patient is going for venous outflow obstruction disease condition, he will be having increased venous pressure within the fistula cannulation site, right? So rapid post-dialysis fistula bleeding with difficulty in achieving hemostasis. So in which cases you can see, in case of aneurysm or pseudoaneurysm formation, okay, in case of aneurysm or pseudoaneurysm formation, so the patient will be having rapid post-dialysis fistula bleeding. You know what is meant by aneurysm? Aneurysm is the outpouching of the blood vessel, right? So what is going to happen post-dialysis when the dialysis is stopped and we have to remove the cannulation and everything? The patient will be having severe bleeding because accidentally the puncture, since the vessel wall is so weakened because of the pseudoaneurysm, the patient will be having severe form of bleeding and difficulty in achieving a proper hemostasis, right? So next is thrill absent and root absent over the fistula. In what condition the thrill and root will be absent? If there is a thrombosis of the fistula, okay, any thrombosis or occlusion of the fistula, this is going to cause what? This is going to cause thrill or root absent, and it is one of the most important. With what is the book you prefer on guiding students? See, we have Target I MSc Nursing book. I hope you all know we have a specialized book for Target High MSc. Okay, MSc, CHO, and SNO in combination. That book is maximal enough on my point of view, because I'm guiding the MSc nursing students for a long period of time. And most of the students will be asking me the doubts on the study materials and everything. So most of the students who have cleared, like I'm telling it in very quantitatively, like most of the students, when I directly collect data from them, and they are expressing that Target I CHO book was very helpful for them. And even the practice test, which is there in MSc, the mock test, the practice test, the previous year paper also influenced their preparation so well to crack this examination, so that you people also can use. Okay. Right. Very good. Very good, Huzaif. If there is an obstruction, then you'll be finding there is a absent or thrill in the root. Right. Which finding is most consistent with an AV fistula pseudoaneurysm? Just now we have studied. Now it is going to be very easy for you to answer. Which finding is most consistent with an AV fistula pseudoaneurysm? Obviously, the answer is going to be B. Right, the focal bulging at the cannulation site with the highest risk of, with highest risk of, highest risk of rupture, highest risk of rupture. Right? So no thrill. Very good, Husaif. Very good. So no thrill and brewed in the fistula, it is because of thrombosis or obstruction. We have discussed true dilatation of all the layers of the vessel. When all the layers of the vessels are dilated, it doesn't mean it is an aneurysm. Aneurysm is specifically certain layers will be affected, certain layers will be becoming weak, and there will be outpouching. If all the layers are affected, it is not aneurysm. Cord, pale extremities with absent distant pulses. This is also because of the obstruction, not because of AV fistula pseudoaneurysm. So next we will go to the next question. Symptoms of Graves' ophthalmopathy include all the following except. Yes. So Huzaif, you can directly contact with me in my social media handle. I have a page, Nursing with Priya Balan. Okay, you can drop a message to me and you can contact me directly through that handle, so that I'll be helping you out in the career opportunities as well, and guiding you in clearing your examinations as well. You can connect with me with this Instagram page, Nursing with Priya Balan. So now coming back to the question, symptoms of Graves' ophthalmopathy include all of the following except. Now tell me, which of the following is a not component of Graves' ophthalmopathy? Very good, Ashish. It is going to be cataract. Cataract is not a component of Graves' ophthalmopathy. As you all know, a case of the Graves' disease is an autoimmune condition where the patient will be having severe form of hyperthyroidism, right? Because of the autoimmunity, there will be uh, hyperproduction of the thyroid hormone. And what is a very classical thing you have to remember is the patient will be having highest level of free T3 and T4. Specifically, free T3 and T4 will be very high in the examination part. Okay. And the patient with Graves' disease or having the highest risk of arrhythmias, right? Specifically, which arrhythmia is very, very common for this particular patients? It is atrial fibrillation. Atrial fibrillation is very, 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 very common arrhythmia, which is accompanied with your Graves' disease. Along with that, the patient will be having restlessness, anxiety, tremors, tachycardia, palpitation, right? And bone mineral density will be reduced. These are all the findings which we can see in Graves' disease, but cataract is no more the component which is associated with Graves' ophthalmopathy. Even we'll be having dermatopathy, but we will not have cataract. There will be no opacification of the lens and all will be seen in case of your Graves' ophthalmopathy. Obviously, you know, exophthalmos will be seen very prominently. Eyeballs will be bulging out and dry and irritated eyes because of the over bulging and over extraction of the orbits. What will happen? The patient will be having dry and irritable and puffy eyes. And light sensitivity, photosensitivity will be definitely there for these patients. Very good, Husaif. And I think you're ready for the examination. You're so powerfully answering. Good evening, Priyaksh. Some students are joining late because it was in hurry that we have to start the class from 3. But next time I'll make sure I'll start at 4 only so that most of the people can connect with me. Right? Okay. So next, what is the most common cause of post-transfusion hepatitis? Now waiting for your answers. What is the most common cause of post-transfusion hepatitis? Yes. What is the most common cause of post-transfusion hepatitis? It's either A, B, C, or E. Very good. Obviously, hepatitis C is the correct answer. The post-transfusion hepatitis is very common in hepatitis C. So if you're going to compare, if you're going to compare First, it will be higher in C, then it will be B, and then it will be A or E. Right? This is very negligible, but after C, if C is not in the option, then you're going to take B only. But the most common post-transfusion hepatitis will be C only. Before this HCV screening, okay, before this HCV antibody screening and NAT screening, HCV antibody screening and NAT screening, nucleic acid amplification test screening, the risk and chance and mortality of post-transfusion hepatitis is very higher. Because of this, yes, hepatitis C, also called as post-transfusion hepatitis, is competitive exam point of view. You can learn from the comments also from the students. Very good. Right. So when this HCV antibody screening and NAT screening was not there, the prominency and the mortality because of hepatitis C infection was very higher, right? But now currently, since we have this HCV antibody screening and NAT screening in the blood components, so the risk and chances of hepatitis C is reduced drastically, but it is not reduced that much. But in some cases, in exceptional cases, because of any sampling error or something like that, there is a lot of chances. Till date, the risk of hepatitis C is very higher in post-transfusion cases, right? So what about hepatitis A? Hepatitis A is not because of any blood product transfusion. It is the transmission is fecal-oral route. The transmission is fecal-oral spread of virus. Here, where we will be doing this HbAg testing and all. And what about your hepatitis B? Hepatitis B, you will be testing about HbAg, and all these components will be tested under hepatitis B, and it is less common among post-transfusion. So next is your hepatitis E. Again, it is also fecal-oral transmission, and there is no higher interaction with blood transfusion, right? So next one. Which of the following is the most common long-term complication of intestinal stroma? So intestinal stroma means they're talking about the colostomy stroma. They're talking about the colostomy stroma. Now tell me, you all are very much aware about the short-term complications of the colostomy stoma, but now I'm asking you a question so differently. What is the long-term complication of the colostomy stoma? Very good. ANE or fecal-oral transmission. Yes. Now tell me, what is the long-term complication of the colostomy stroma? Any idea? Skin excoriation, redness, grayish deposition. These are all short term. What is the long term? C. People are telling C. Yes, the correct answer is B. Your parastromal hernia is the most common long-term complication of the colostomy. So here you can see the image of your parastromal hernia. Parastromal hernia. So here you can see the image. Okay, because of the weakness of the abdominal wall, okay, weakness of the abdominal wall around the stroma, the herniation will be happening for the other structures. Whenever there is an end colostomy, there is highest risk of getting, the patient may get in a parastromal hernia. And this is because of most like, the procedural errors. If they are not properly working on the colostomy surgery while creating the stroma, the patient may have the highest risk to get this long-term complication of your parastromal hernia, right? Weakness of the abdominal wall around the stroma. Because of that, what will happen? The increased intra-abdominal pressure will allow the herniation of the intestine into that particular weakened abdominal wall, and you can see the bulging around the stroma. Yes, yes, yes. Right? So this is your parastromal hernia. Right? What about your skin excoriation? The overall most common early complication early complication because of the fecal material, the overall most common early complication is your skin excoriation. Right. Prolapse is also a long-term complication, but it is very less common when comparing to your parastomal hernia. So retraction is a rare complication, right? Prolapse can also happen if parastomal hernia is not there. You should tick prolapse only, right? Is that as clear? Yes, we will go to the next question. This is the parastomal hernia question. If you get an image-based question also, you should try to identify what is parastomal hernia. Parastomal hernia is a long-term complication of the intestinal stroma or the colostomy stroma, right? So the next question, while caring for an 84 years old patient, the nurse monitors the patient fluid and electrolyte balance, recognizes which of the following is as a normal change of aging. So I'm monitoring, as a nurse, I'm monitoring the electrolyte imbalance of a aged population, right? Older age population, 84 years old, right? The geriatric population, to be very clear. So what particular electrolyte imbalance I consider it is normal at this age? Tell me. Now tell me the answer. Why this particular thing? I'm telling it is very normal for the age. Many people are telling C. Is C is the answer? Decreased insensible loss. You people are telling the patient will be the patient will be having decreased insensible loss or increased insensible loss. Yes, come on. The skin is going to become, as the population, as the age increases, the skin is going to become more thin. Okay, more thin. It is going to lose its elasticity, more fragile. Okay, more fragile. And reduced ability to conserve water. It has a reduced ability to conserve water. Yes, C is going to be the correct answer. Now tell me. The patient will be having increased insensible fluid loss. It is not decreased. Now tell me. Yes, now tell me what is the correct answer. Now you have learned, right? You have learned about decreased insensible fluid loss. It is going to be increased in case of adult population. See, the most important thing you people have to remember is hyponatremia. Hyponatremia in elderly population with a proper amount, it's considered to be normal because hyponatremia is an expected age-related changes in the electrolyte, which you can find. Hyperkalemia is not a component and increased plasma oncotic pressure will not be there. Just now in the first question, we have studied about plasma oncotic pressure. When in the aging population, ultimately the protein level, the energy level, the metabolism, everything is going to be reduced. So obviously the oncotic pressure is also going to be reduced. If the oncotic pressure is going to be reduced, what is going to happen? If the oncotic pressure is going to be reduced, the shift of fluid from the intravascular space to the extravascular space will be happening. So if this is going to happen, the patient will be going for edema also. That's why we are advising frequent change and proper fluids or administered to the patient, right? So hyponatremia is considered to be the normal electrolyte change which you can see. But classically, we can have a deep dive into this particular component, right? So first and foremost, the primary reason why we are considering hyponatremia is normal in case of elderly population is, right, the patient's ADH level will be altered, right? So your sodium has an important interaction with a condition called as your SIADH and your diabetes insipidus, as you all know. So for example, if the patient is going to have excess ADH, okay, excessive antidiuretic hormone if the patient is having. This excessive antidiuretic hormone, it is going to constantly work on your renal system, and it is going to make lot of water absorption or reabsorption. So excessive antidiuretic hormone, it is not diuretic hormone, it is antidiuretic hormone, which means it is going to stop the diuretic effect. So if diuretics we are giving, there will be more urine. But if you're going to give antidiuretic, it is going to reduce the urine level, right? It is going to increase the water reabsorption, right? So what is happening? There will be excessive water retention. So when there is an excessive amount of water retention in the body, the sodium will become so diluted. That's where we will be classically telling a important point. That is your dilutional hyponatremia. So dilutional hyponatremia is a classical feature of your SIDH. Obviously, the osmolality is going to be reduced. What does it mean by osmolality? The amount of solutes which is present in the blood. That is your blood osmolality, which means I have more water. So there is very less solute. So what will happen? The osmolality is going to reduce. That's where you can say dilutional hyponatremia also. On the other case, there is a deficiency of ADH. The ADH in the body is very much reduced. Obviously, this water retention is going to not happen. There will be excessive amount of free water loss. There is going to be an excessive amount of free water loss. When there is an excessive amount of free water loss, excessive body is losing the water. So what will happen? The sodium concentration will be becoming very higher, which is going to lead for hypernatremia, So this is a classical condition, deficient in your antidiuretic hormone. That what is going to happen? The condition is diabetes insipidus. As you all know, there is a deficiency or a reduced amount of ADH production. So here you can see hypernatremia. So now tell me, what is the management of your diabetes insipidus and SIDH in the comment box? So if there is a normal ADH, it is a normal finding. Now you people have to comment me. Yes. Yes, very good. Euvolemic hyponatremia can also be seen. So now tell me, what is the management of SIDH and diabetes insipidus? So definitely you people have to put in the comment box. So now, yes, artificial vasopressin antidiuretics will be given. Desmopressin is a drug of choice. Very good. Very good, very good, very good, very good. Yes. Vaptans are given in case of your SIDH and your presence, desmopressins, artificial or synthetic formulation of ADH are given in case of your diabetes insipidus. So Vaptan drugs, what are Vaptans? Tolvaptans. These are drugs which will cause the effect on this SIADH. Very good, very good, very good. Who has answered it? Huzaif, very good, very good. Tanya, very good, very good. Priyansh, very good. Okay, the next question. A patient present with hemothorax and required chest tube placement to drain the blood accumulation in the lower part of the lung. Already the question is very, very easy. Where does the chest tube to be placed for effective draining of the fluid? Sorry, of the fluid. So hemothorax is, that is a blood accumulation in the lungs. Now tell me, where we will be placing the chest tube. Obviously, apical is the upper aspect. When it is a pneumothorax, right? When it is a pneumothorax, it is going to be A. But here it is a hemothorax, which means according to the gravity, according to the environment, the fluid is going to be accumulated in the lower aspect only. So in the basilar area, if you're going to put the chest tube, you can easily drain all the blood. In apical area, you cannot able to do it. So if they have given the scenario, it is a pneumothorax, then you're going to take it as an apical area. Mid lung zones are not used and subdiabetic is never ever used. Right. Now tell me, chest tube insertion. Always chest tube is inserted in the upper border of the rib. Always it is inserted. Your chest tube is inserted in the upper border of the rib. Why it is not placed in the lower border of the rib? Anyone can tell me in the comment box why it is not placed in the lower border of the rib? Because in the lower border of the rib, in the lower border of the rib, there is a neurovascular bundle, okay, where important neurons and circulatory system neurovascular bundle is there. So always the preferred site is upper border of the rib, right? So hemothorax is a very, very important condition, as you all know. Now tell me, what are the clinical features? What are the clinical features of hemothorax? In the comment box. Yes. Very good. To prevent injury, very good. There is a rich blood supply and nerve supply. Very good, Priyansh. So, to be very classically, you can tell it like the neurovascular bundle is present in the lower border of the rib. So, we are always preferring upper border of the rib. Right. Now, tell me the clinical features of hemothorax. That is also very frequently tested in the competitive examination. Right. Your systolic blood pressure is going to be decreased. The reduced systolic blood pressure. Since you people are studying for a competitive examination, it is not necessary that you have to generalizely you have to answer. You should be very specific. If at all you're telling there is an hypotension, you should be very clear to tell either it is a systolic hypertension or a diastolic hypotension. Right? Your systolic blood pressure is going to be very much reduced in case of your hemothorax. And what about your heart rate? Since the systolic blood pressure is reduced, obviously your heart rate is going to be increased. Yes, hypotension is seen in case of hemothorax. Be very classical. Hypotension learning is very good, but you also have to remember it is a systolic blood pressure reduction, hypotension. Then there will be reduced cardiac output. There will be reduced cardiac output. Then what are the other conditions? What the other thing? On percussion, what will be the finding in case of hemothorax? Now tell me. On percussion, what is the finding? Very good. Tachycardia. Very good, Priyansh. Now tell me, what is the percussion finding? The percussion finding, it is a dull note. Always you will hear only dull note if the patient is a case of hemothorax. Then what about the breath sounds? What about the breath sounds? See, very classically in competitive exam centrically, you have to tell it is a dull note, not crackles. Crackles are very classical in case of your pneumonia, not in case of your hemothorax. In hemothorax, on percussion, you will be seeing a dull note. The breath sound is going to be absent. This is again a very, very important point you have to remember while studying about hemothorax. The important management is already we have discussed, that is chest tube insertion. Chest tube insertion. The important management is chest tube insertion. Right? Very good, very good, very good. So next we'll go to the next question. Copper nail sign is seen in which of the following condition? Now tell me, copper nail sign is seen in which of the following condition? First, what is copper nail sign? What is copper nail sign? If it is very new for you, copper nail sign is the ecchymosis. Yes, yes. Like we have to follow the triangle of safety. Very good in chest tube insertion. Very good, very good, very good, very good, Priyansh. Yes. Very good, Tanya. Very good, Tanya. Very good, Tanya. A is the correct answer. Copper nail sign is seen in case of your pelvic fracture. The classical sign of your pelvic fracture is copper nail sign. Now I will tell you what is copper nail sign. Copper nail sign is the ecchymosis. Of your perineum, scrotum, or labia in case of a female client. In case of a female patient, the labia, the perineum, the scrotum in case of male patient, if there is an ecchymosis in these regions, that is a classical feature of your pelvic fracture. That is a classical feature of your pelvic fracture. Ecchymosis or bruising, everything is the same meaning. Very good. So just remember about this. Copper nail sign is classically seen in case of your pelvic fracture. Right. On the other hand, just now we have studied about copper nail sign, that is perineal and scrotal ecchymosis in case of pelvic fracture. So as you all know, gray Turner sign, which is seen in case of your pancreatitis, where there is a flank ecchymosis. Just remember gray Turner sign, which means if I'm going to turn to one end only, you can properly examine my flank. Right, that is the flank ecchymosis. Cullen sign, it is a peri-umbilical ecchymosis, which means around the umbilical area, there will be the ecchymosis that is termed as your Cullen sign. That is also happening in the case of your pancreatitis. Fox sign is an inguinal ligament ecchymosis, which is because of the retroperitoneal bleeding. Right? Very good. So the next question. Which of the following is contraindication for using metformin in patients with renal impairment? Classically answer these questions. These are very, very important questions. Yes. Yes, now tell me, which of the following is a contraindication for using metformin in patient with renal impairment? If GFR is less than 30, very good, Huzaif. A is the correct answer. This is the this is the level. Like, if the GFR is going to be less than 30 ml per minute, it is highly or absolutely contraindicated to administer metformin. As you all know, metformin will be unchangedly excreted in the kidney. It is unchangedly metabolized in the kidney. Right? When there is a renal impairment, this drug will be not excreted properly and it is going to accumulate in the body. So now tell me, what is the complication which is going to happen when the patient, we are administering metformin for the patient whose GFR is less than 30 ml? The primary and most important complication is lactic acidosis. Lactic acidosis. Right? This is again a very, very important point you people have to remember. So what is metformin? Metformin inhibits glucogenesis, right? Metformin inhibits gluconeogenesis. So thereby, it is reducing the sugar level, right? So what is the component which you have to remember here? The side effects of metformin. First is lactic acidosis, as we have discussed. So what are the other side effects of metformin? Answer in the comment box. What are the other side effects of metformin? One is lactic acidosis. It lowers your B12 level. It lowers your B12 level. And it causes loose stools. Diarrhea. Very good, very good. Many additional informations are given in the group, given in the chat box. It is very nice to hear. Very good, very good. Yes. Right? Megaloblastic anemia because of the low B2 levels. Right? We'll go to the next question. Identical twins have similarities in all except. Now tell me, it is a common sense. Use your common sense and answer for this question. Identical twins will have similarities in all except. Identical twins will have similar blood group. Very good. Fingerprinting will not be having like fingerprinting will not be having a similarity in case of identical twins also. Either, maybe they are monozygotic or whatever. Like fingerprinting will be different for each and every individual. Why fingerprinting is different for each and every individual? It is not at all inherited. It is not at all from the paternal side. So it is always like because of the environment, because of the movement inside the intrauterine period, the fingerprint has will be having a modification, right? So that's why fingerprinting is a component which is not at all similar between the identical twins as well, right? So next question. During the placement of central line, a patient begins to experience sudden shortness of breath. Suspecting an air embolism, in which of the following position should the nurse immediately place the patient? A very, very easy and a very commonly asked question in your competitive examinations. Yes, it is unique in every individual. That's why in your Aadhaar card, they are taking fingerprints, right? Everywhere they are using your fingerprints to have your specialized identity. They are not using any other things, right? So use that common sense also while answering the questions in the competitive examination, right? Yes, very good. Left Redlenberg is the answer. As you all know, when you're going to place the patient in the left Redlenberg, what it is going to do, it will make the air emboli, okay, the air emboli to stay in the right atrium itself, preventing its entry into the right ventricle. Thereby, it is going to occlude your pulmonary artery. So this will be prevented when the patient is placed in the left Trendelenburg position. Okay, trapping the air in the apex or in the right atrium of the heart. So that's why we are immediately putting the patient who are at the risk of air embolism into left Trendelenburg position. Right? So the next question, a nurse is assessing a patient with cardiovascular disease and hypertension who is receiving metoprolol. Which of the following finding would be most urgently required for the nurse to follow up? Now tell me, the patient is assessed for cardiovascular disease and hypertension who is receiving metoprolol. Which of the following finding would most urgently require the nurse to follow up? Yes, I'm waiting for your answers. In what cases? What case is very urgent? Just think common with the common sense. Waiting for your answers. See, this is one more thing. As a student psychology, whenever you see a question paper, whenever there is a quantitative data, you choose that particular data as a correct answer. We as examiners, we play with that particular psychology aspect. Right? Yes. Tagro. Please give a big round of applause to that particular student. Headache and nosebleed is the correct answer. And one more thing, trick also you can use. So since all the three option is having a quantitative data, numerical data, you've been confused and your mind is wandering again these three only, right? Okay, either A, B, C will be the answer, then you'll be thinking on that only. But all the time it is not the case. And one more thing you have to remember is, if at all the patient, if at all one option is not so much coinciding with others, which means there is a numerical similarity between three options, which means they may be the distractors, right? Headache and nosebleed, right? Headache and nosebleed are the primary, most urgent required monitoring and follow-up. Why? This headache and nosebleed for a patient who is receiving metoprolol. Patient is already a case of cardiovascular disease and hypertension. Headache and nosebleed is indicating the patient is at the higher risk of getting hypertensive crisis. Hypertensive crisis, right? So when the patient is going to be at the higher risk of getting hypertensive crisis, at that time, headache and nosebleed are the most important components you have to note. Right. So hypertension is the primary, hypertensive crisis is the primary priority which you people have to think. So heart rate decreasing 75 to 63. Obviously, metoprolol is an antihypertensive drug and it will be reducing the heart rate. It is expected and it is within the normal range. The urinary output for 3 hours, it is normal. And lipid level, we will monitor lipid level in various conditions. Already the patient is a case of hypertension. Okay, we have already, the question is telling already the patient is a case of cardiovascular disease and hypertension who is receiving metoprolol. He is on the antihypertensive therapy. So whenever he is going for hypertensive crisis, that time only you can see this particular symptoms of headache and severe nose bleeding. Or it may also indicate other severe form of serious complications as well, right? So you have to give an importance to this only. So now tell me, beta blockers are administered in what other cases? Hypertension, we have discussed. In case of migraine, also the beta blockers is the drug of choice, right? So the urine output when comparing to the other parameters such as headache and nose bleeding, it is not that much important. So you should always act on priority based choose up rather than generalized things, right? So first is beta blockers, migraine. In case of migraine, you'll be administering. In case of hyperthyroidism, okay. In case of hyperthyroidism also, the drug of choice, you're using beta blockers in the management. In case of stable angina, and in case of anxiety disorders, then any other option? In case of essential tremors, we are using beta blockers as the drug in the management, right? Apart from antihypertensive property, beta blockers are also administered in case of your migraine, hyperthyroidism, stable angina, anxiety disorder. But the name of the drug may vary. Like for example, metoprolol and propranolol, and based on the particular conditions, the drug will be chosen. But beta blockers are also used in these particular conditions as well, right? Yes. So, contraindication of beta blockers, anyone? Contraindications of beta blockers. If the patient is a case of heart block, already there is a conduction block. Again, you should not give the rate controller. In heart block, already the heart rate is going to be drastically reduced. So here, there is no use of giving the rate controllers. That is also very, very important point you people have to note. Right. Which of the following is a characteristic symptom of achalasia cardia? As you all know, what is achalasia cardia? Achalasia cardia is a condition where there is a lower esophageal sphincter is failing to relax. Achalasia cardia is a condition where your lower esophageal sphincter fails to relax in response to the swallowing, right, in response to the swallowing. So what is the primary? Yes, very good. Students were answering bradycardia and asthma. Very good. What is the interaction of asthma? Beta blockers can cause bronchoconstriction, right? Bronchospasm. That's why, in case the patient is a case of asthma or COPD, that time in the antiarrhythmic in the antiarrhythmic drug in the antiarrhythmal drug classification, if the patient is a case of asthma and COPD, we are not administering beta blockers. We are going for calcium channel blockers. That time we will be using verapamil and diltiazem if the patient is a case of COPD or asthma, because beta blockers can cause bronchoconstriction. Right? Very good. Very good for adding this important point, Pooja and Leonard. Right? Yes, regurgitation is the earliest sign of symptom of Achalasia cardia is very good because of the esophageal, lower esophageal sphincter is failing to relax. What is happening here? Here, the primary symptom is regurgitation, frequent regurgitation, and dysphagia for solids and liquids. In certain condition, for liquids, there will be no regurgitation. In other esophageal conditions, okay, but in case of Achalasia cardia only, for even for the liquids and even for the solids, the patient will be having dysphagia, difficulty in swallowing, and the frequent regurgitation you will be seeing. Acute epigastric pain is seen in all the conditions which is relating to the GI, and jaundice and dark urine are not a component, and frequent vomiting of blood. Hemoptysis, like hematemesis, like in case of very severe condition, we can go, but it is not a classical feature of Achalasia cardia. The characteristic symptom which is given along what is given, the primary thing you have to remember is dysphagia on solid fluids. Like very good. Some people have administered some people have said like bird beak appearance is one of the classical feature of Achalasia cardia in the barium swallow. Very good, very good. So next question. What is the classical tympanic membrane sign of acute otitis media? A very easy question again. What is a classical feature or classical sign which is seen in case of your tympanic membrane on tympanic membrane examination if the patient is a case of acute otitis media and he is going into suppuration or pre-suppuration stage? Either if the question is telling acute otitis media, or it may be a suppuration or pre-suppuration case also, that will be the answer. Now tell me what is the answer. The answer is cartwheel appearance. So here you can see this is the cartwheel appearance, looking like a cart. You can see, right? Bullock cart wheel. So that is termed as your cartwheel appearance. This is seen in case of your acute otitis media, either in the suppurative phase or in the pre-suppurative phase. In all the cases, you can see this cartwheel appearance of the tympanic membrane. So there will be a red and bulging with decreased right reflex. There will be a red and bulging tympanic membrane with decreased light reflex will be seen in case of your acute otitis media. Cartwheel appearance is one of the classical feature of your acute otitis media on tympanic membrane examination, right? So next, at what dose is paracetamol considered to be toxic range requires urgent medical intervention? Again, these questions I'm expecting in all the competitive examinations. Now tell me, at what dose is a paracetamol considered to be in a toxic range requiring urgent medical intervention? What is the toxic dose of paracetamol? Classically, give me the answer. Hmm. 5 grams. 5 grams. Somewhere you are correct. Some student who are telling Leonard 5 grams you are telling now. It is correct, dear. But there is a range. So potential toxic range. The potential toxic range, which means if it is going greater than this range, the ability or the chance of getting toxicity of paracetamol is higher when it is going greater than 4 grams. Greater than 4 grams, we are telling it is potentially toxic, which means if I'm going to have the range of the paracetamol more than 4 grams in my body, I'm at a higher risk of getting paracetamol toxicity. But I'm asking what is a toxic range? This is a potential toxic range where you can choose 5 gram, but you're asking actual toxic range. Yes, 4 gram is a dose. Very good. 4 gram is a dose. But remember the actual toxic dosage of paracetamol, where this therapeutic level, this particular level is going to cause the toxicity. That is, if it is going greater than 7.5 gram. This is a toxic dose of paracetamol. This is a toxic dose of paracetamol. Please remember this. Potentially toxic. The risk of getting toxicity is more higher when it is going greater than 4, right? But the actual toxic dose is greater than 7.5 grams. This you have to remember, right? So if that is not there, then you will be choosing other options. But actual toxic dose, you have to remember greater than 7.5 gram. The potential risk for becoming toxic will be greater than 4. Right, Tanya? Yes, very good. So now tell me, so some of the not set questions. Let's discuss. Anaphylactic shock is classified under which type of shock? Very simple question, but many of the many of the rapid preparers of the examination students or aspirants also making mistakes in these kind of silly questions. Yes, now give me the answer. Anaphylactic shock is classified under which type of shock? Yes. Anaphylactic shock is classified under distributive shock, right? Anaphylactic shock is classified under distributive shock. So what is happening in the distributive shock? Please add in the comment box. Very good, Tanya. Very good, Priyanshu. Very good, Leonard. Very good. So now tell me what is happening in distributive shock. It causes massive vasodilation. Okay. Massive vasodilation. Okay, there is massive vasodilation which is causing improper supply of blood to the various systemic organs, right? In anaphylaxis, what will happen? In anaphylaxis, there will be hyperactivation of the histamines, hyperactivation of the inflammatory mediators, and there will be profound vascular dilatation, which decreases the systemic vascular resistance, thereby there is no proper circulation to the systemic organs, right? Now tell me, what is the management, which is frequently asked in examination? Management of anaphylactic shock. What is the drug of choice? Your drug of choice is epinephrine, as you all know. Now tell me the dosage and route of your epinephrine administration in case of your anaphylactic shock. Epinephrine is administered in the intramuscular only. In intramuscular, the dosage is 0.3 to 0.5 mg. What is the dilution? It is 1:1000. It is 1:1000 dilution. Very good, very good, very good. It is 1:1000 dilution. The primary site which we are preferring, that is your vastus lateralis, that is your anterolateral thigh. Anterolateral thigh, right? In case of pediatric population, what is the dosage? Any idea? In case of pediatric population, what is the dosage? Remember, it is 0.01 mg per kg. 0.01 mg per kg. Maximum you can give 0.3 mg in case of pediatric population. Every 5 to 15 minutes you can repeat the dosage, but this is the dosage for your pediatric population. Very good. The dilution is 1:1000. All the points or important point which can be asked in your examination. Right? Next. Conscious sedation is best described as. What is meant by conscious sedation? Tell me in the chat box. Conscious sedation is best described as. Conscious sedation is best described as, which means conscious sedation means the patient is conscious and he is easily arousable. Okay. The memories are intact. So what are the example drugs you can get? Like the patient is responsive to the verbal commands, protective airway reflexes are there, and he has adequate spontaneous ventilation. Right. So now tell me, what is conscious sedation? See, in case of general anesthesia, no. Conscious sedation is not general anesthesia. See, in general anesthesia, what is happening? In general anesthesia, it involves complete loss of consciousness. Even the airway, we will be supporting the patient, right? Complete loss of consciousness. Right? Mild anesthesia, there is no such term. Deep anesthesia, no, it also involves depression of the consciousness. So moderate anesthesia is described as a conscious sedation. For example, the drugs such as midazolam, short-acting benzodiazepines, Yes, it is moderate. Very good. Short-acting benzodiazepines. Example is midazolam. In this case, only what we are doing, the patient is easily arousable. He is conscious. We need not to give any form of additional mechanical ventilatory support to those patients. So that's why we are telling it is a conscious sedation. Right? Quickly, we will go to the next question. A patient is admitted with a thrombotic stroke. Which priority nursing assessment in first 24 hours is so mandatory? A patient is a case of thrombotic stroke. Which priority nursing assessment is the first in the first 24 hours is so mandatory? Yes, B moderate is the correct answer. Now let's answer for the next question. Yes. What is the correct answer? Priority nursing assessment in the first 24 hours for a thrombotic stroke patient. Very good. Pupillary size and pupillary response. So patient is a case of thrombotic stroke. You should be very cautious about the ICP, intracranial pressure. The rise in intracranial pressure can be easily identified with the help of the pupillary size and your pupillary responses. When comparing to your bowel sounds, echocardiography, cholesterol, even echocardiography, like it is important, but when interacting with the question, you should be very specific. So ICP is a primary concern. ICP assessment can be done with the help of the pupillary size monitoring, right? So that's why that is the correct answer. No, echocardiography will not be the answer. So next, a patient 6 hours post CABG has chest tube drainage of 250 ml per hour for 3 consecutive hours. For example, so for 3 consecutive hours, which means he has 250 ml, 250 ml, and 250 ml for the past 3 hours from the chest, from the CABG, mediastinal drainage. So along with hypotension, again, the patient is also going for hypotension. So it is ultimately, it is indicating the patient is going for hypovolemic shock, right? Because 250 ml per hour is not an appropriate drain amount from the CABG. The normal expected amount of drain is only 100 to 150 ml per hour. That too, initially we are expecting this in a CABG, right? But in this case, if you see, the patient is going more than, like, it is 750 ml, right? It is very high, and it is indicating the patient is having hemorrhage, right? The patient is having hemorrhage. Very good, Tanya. Very good, Leonard. Very good. Right? So the patient is going for hemorrhage. So ultimately, that will be the complication which has arisen. So the next question. A 65 years old patient with a history of diabetes mellitus and coronary artery disease present with dizziness and near syncopal. So no need to skip those questions. So here the ECG is missing. Okay. For example, the ECG is having a complete heart block. Complete heart block was the ECG given. What is meant by complete heart block? As you all know, there is no association between the P wave and QRS. The P wave and QRS, which means there will be no interaction between the atrial contraction and ventricular contraction as such, without getting proper conduction. P wave will be happening at one end and QRS will be happening at one end. So if the patient is a case of complete heart block, what is the management? Obviously, transcutaneous pacing. As you all know, when the patient is going for second degree type 2 or complete heart block, the primary management is going to be transcutaneous or transvenous pacing. Atropine is a drug of choice in case of heart block when it is a symptomatic heart block. That too in case of first degree and second degree type 1 when there is no severe symptoms. If the patient is not having any severe form of atom stroke attack and all, we are giving atropine. But if the condition is worsening at that time, transcutaneous or transvenous pacing is a primary management. This is very important point you people have to remember, right? Yes, transcutaneous pacing will be important management. Atropine is a drug of choice for heart block. When there is a question, you have to take that only, right? But you have to remember that is only manageable if it is first degree or second degree type 1, right? So a patient is in the immediate post-operative period after adrenalectomy. So what is the nursing priority concern? A patient is in the immediate post-operative period after adrenalectomy. So what is the nurse's priority concern? Risk for wound infection. See, adrenalectomy is performed in case of Cushing's disease, right? So when the adrenal glands, either bilateral or unilateral adrenalectomy is done, there may be the fluctuation in the blood glucose. Either the blood glucose may decline or the blood glucose may increase, or either it may decline based upon the corticosteroid therapy which the patient is going to receive, right? So it is very important to note this thing. So monitoring the blood glucose is very important if the patient is a case of post-operative adrenalectomy, right? Yes. So the last question, a patient is receiving heparin, has the APTT at 85 seconds. What is the most appropriate next action? The most important thing you have to remember is the therapeutic level. The therapeutic range of heparin. Sorry, the therapeutic range of APTT. What is the therapeutic range? Very good. What is the therapeutic range of APTT if the patient is on heparin therapy? it is somewhere between 46 to 70. Right. But here it is drastically higher. So ultimately we have to hold the heparin. So as we have already discussed, if the patient is on warfarin, monitoring is required. What we monitor, that is PT and INR. If the patient is on heparin therapy, as you all know, you have to monitor activated partial thromboplastin time. Right. And what in other cases, either like in heparin also, it is very, very important. You have to remember, in case of unfractionated heparin, or parental direct thrombin inhibitors, in that case also, you will be monitoring APTT only. PT-INR is monitored only in case of warfarin. Monitoring is not required in what cases? In what cases monitoring is not required? Here the monitoring is required. When I'm taking warfarin, I have to monitor PT-INR for the patient. When I'm taking heparin or unfractionated heparin or parental direct thrombin inhibitors, I have to monitor APTT. When I'm taking which kind of anticoagulant, I do not need any form of monitoring. That is your direct oral anticoagulants. Your apixaban, rivaroxaban, and all. And your low molecular weight heparin does not require monitoring. Your fundaparonex does not require monitoring. So remember, these does not require monitoring, but these set of anticoagulants definitely require monitoring, right? So with this question, we will end the session. And thank you so much for everyone who is with me. I hope I have delivered a good knowledge sharing session with you, and just drop in the comment box like how was your experience with the class, what and all you need in additional. Okay. And thank you so much for the students who were completely with me. For example, Tanya, Leonard, Aish, Priyansh, and everyone. So this kind of active learning and patience is required when you're preparing for a competitive nursing examination, right? Thank you so much for watching. All the very best for your upcoming examinations. It can be any examination. It can be an MSc Nursing entrance examination, or it may be any kind of competitive nursing examination. My heartfelt wishes for your upcoming examination. So if you want to connect with me, you can connect with my Instagram handle, Nursing with Priya Balan, or you can also scan the QR code to follow me. And if you have any doubts on pharmacology or adult health nursing, you can connect with me. Right? Thank you so much for being with me, and thank you so much, my dear students. Yes.